part of the update course, and I'm going to turn things over to Von Allman in a second. Part of the update course is to show all these new, just like what Roshni just showed, all these new and exciting things that are brand new and great for pediatric surgery. But maybe part of the update course should also show things that we need to update ourselves that may not be as exciting as we thought. So we're presenting a concept here that is very exciting, that is very new, but I think you're going to hear two sides to the story. So Dan, do you want to take it over from here?
Sure, happy to introduce it, Todd. It is we're going to finish up once again with a completely non-controversial topic for which the therapy is very straightforward, and that is long gap esophageal atresia. And you know, this is a challenge. It can be an incredibly difficult thing to treat, and people have done lots of work to try to figure out a better way to treat it. And one of those ways is to use magnets to pull the two ends of the esophagus together. And so we're going to have a couple presentations here. First, we're going to have Dr. Slater present on her experience with magnets. And then we'll have the venerable Dr. Rothenberg present his experience with the magnets. And we'll have a discussion about what the options are and the potential use for this new technology. So Bethany, take it away.
All right, well, thank you very much. And thanks for staying for this last presentation. Of course, always fun for me to be talking before Dr. Rothenberg, but I'll do my best here. I'll keep this fairly short as well so that we can have some robust discussion. But we'll start with a poll here. So this question is a 3-month-old male who has a history of a cardiac anomaly with a type A esophageal atresia or a pure esophageal atresia, who had a gastrostomy placed after birth and then had a gap study at, again, about 3 months of age, demonstrating a 3-centimeter gap between the proximal and distal esophagus. What would the next step be for an operative plan? So A, either an open thoracotomy with esophageal repair, a thoracoscopic approach to esophageal repair, esophagoscopy, or placement of magnets. While we're waiting for this poll, Dr. Harmon, why don't you tell us what you would respond to this?
Dr. Harmon may have bailed on us.
He had an emergency that came up and just had to leave. He was supposed to be moderating this with you, and part of that is because
he's back, Todd.
Yeah, I do. I love the question. So I would 3 centimeters is overcomable. So I would try that thoracoscopically and get those two ends together. And if you needed to do something different in the middle of the case, you could do that.
Great. How about the results from our poll here?
Sure. So more, it's changing, it's still changing by the minute, but more than half are saying the thoracoscopic repair. And then the next most common is placement of magnets, and last would be an open thoracotomy.
All right, great. So I think most of these options are certainly possibilities, but for the point of this particular talk here, we're going to use this to highlight the discussion about using magnets for esophageal atresia. So in general, magnets have actually been used for many, many years, and specifically for esophageal atresia. But they can be used as a non-surgical alternative for esophageal anastomosis, and they're able to promote lengthening and approximation of the proximal and distal end of the esophagus. And then it uses compression anastomosis to create continuity of the esophagus. So this picture here shows the Flourish device. It's a catheter-based magnet system, and that's what I have experience with, but there are some other magnets that have been used in the past, including Mike Harrison has one that's being used now, primarily for strictures though. So again, this is one particular type that uses magnets as the device using catheters. But just in brief, again, the magnets go on the proximal and distal part of the esophagus. They lengthen and attract one another. And then the compression anastomosis works by causing ischemia of the tissue between the two, and then that sloughs off and that creates the anastomosis. So just a little more specifically about the Flourish device. As I mentioned, I think that it's an FDA approved, commercially available device. It is a humanitarian device exception from Cook Medical, and it has both the esophageal and gastric catheters that have inner bullet-shaped magnets on each end. And it does, which is very important to note, that it does taper down to a 10 French coupling surface. Proximal catheter does have a suction port, so that can be used to suction the saliva for the patient while it's being used. And the gastric port has a portion for feeds as well. This is a table that just shows some of the studies that have been previously published with Flourish magnets. So there are a couple of case reports and some series that show success with using the Flourish device. Of note, almost all of these patients did have strictures postoperatively. And then just a tiny bit more detail about a study that we published about 2 years ago now, looking back retrospectively at all the available data using the Flourish magnets. There were 13 patients over 17 years in a couple different countries, and all of these patients were able to achieve anastomosis. Although of note, all of them did have a stricture, as mentioned previously, and 2 of the patients did require surgery for recalcitrant strictures postoperatively after the magnet placement. There is currently a prospective single-arm observational study. It's the post-FDA approval study that is ongoing right now. It is a Cook-sponsored study, and currently there are about 12 patients or so that are enrolled in this study. There have been more that have placed outside of the study as well. And I really wanted to focus a little bit on the fact of the eligibility for both the study as well as for placements of the Flourish magnets. So there needs to be a gap length of less than 4 centimeters. And if the lengths are greater than that, the magnets will not attract one another, so they can't be used. Additionally, and also very importantly, there needs to either be an absent fistula, so as in a pure esophageal atresia, or a fistula that has been previously repaired. And the patients do require a gastrostomy that can accommodate an 18 French catheter, because that is the diameter of the gastric portion of the catheter. Of course, like with any device, it's important to note the indications for use and to proceed with the caveats and the recommendations, from the company. And yes, I believe that is my last slide. So we can move on to Dr. Rothenberg's case and to continued conversation about it. And I'm happy to answer any other questions afterwards.
Great, thank you. Steve, why don't you present your case and then we'll maybe we can discuss it.
Okay. Are my slides going to come up?
Yeah.
Yep, they will.
Okay. So just to say at the beginning, I'm not convinced that there's not a role for magnets in this, but I thought it important to people be aware of some of the issues. And this is a case that I got presented with this last year that I think had significant consequences for the child. And I think it raises some of the questions about the protocol for this device. So this was a full-term male who was born with pure esophageal atresia. He had a gastrostomy placed at birth, and this was not at our institution. At about, 5 weeks of, or about 6 weeks of age, they had a gap study that showed a 3.5 centimeter gap. And then in about a little over 6 weeks later, so 3 months of age, patient had another gap study, which showed a gap of 2.6 centimeters. And at this point, the decision was made to use the Flourish device. I will say, I'm not going to name the institution, but I will say this is not Cincinnati Children's Hospital or Chicago. This is a small institution that does some pediatric surgery, but that yet somehow got approval to use this device. This just shows the gap, you know, at the insertion of the magnets. They put the magnets in. I think it was they had to reposition them once, and I've not used the device, so I'm not totally clear on what all the implications are, but I know you have to have involvement of interventional radiology. The patient was heavily sedated, I think, for 12 days. And they got the esophagus together. 4 days later, the patient had an acute decompensation. He was transferred to another hospital. The hospital where this was done did not have a full-time pediatric surgeon. And so when the patient decompensated, there was no pediatric surgeon at this hospital. He was transferred to another local children's center where the pediatric surgeon worked him up, and they identified a large fistula between the esophagus and the left mainstem bronchus. At that point, the surgeon felt the only way to salvage this was to take him to the OR, did an open thoracotomy, found severe inflammation. He had difficulty in identifying any of the structures. He divided the fistula and then felt the only way that he could safely manage the patient was actually to divide the esophagus again. And now the patient ended up with a gap of 5 centimeters. So the baby was stabilized, and then the question was what to do. You can imagine the parents were quite distraught at this point. They started looking for answers and got on the internet and contacted a couple centers. Ours was one of them. And when I talked with the family, I told them, you know, I really wasn't sure what could be done. I didn't know if the esophagus could be salvaged. They wanted to do a esophagostomy locally and then do some sort of reconstruction later. And I told them I thought there was probably a 50-50 chance we could salvage the esophagus. And they eventually ended up deciding to come to our institution. Got a gap study. And when I did an esophagram of the upper pouch, it showed that there was an upper pouch fistula, which had not previously been diagnosed. The question was whether this was traumatic or, you know, a true upper pouch fistula. And when I scoped the patient, it was a true upper pouch fistula. So one of the contraindications to using the Flourish device, I believe, would be the presence of this fistula, which was unfortunately not looked for, I think, at the initial institution and was missed. So what to do next? So I decided normally I would fix that upper pouch fistula through thoracoscopy. We ligate all our upper pouch fistulas and H-type fistulas now thoracoscopically because I think the view is excellent. We get good control. But because this child's chest was a mess, and he actually was with us, took us about 4 weeks to tune him up before we could do anything. I did a neck dissection, went in and ligated that fistula. Let him get over that for a week, talked with the parents, and then we elected to go in and start. And I don't know, will the video play? Should be.
I loaded it.
Should I click again, or is that?
Yeah, click again.
Okay.
There it goes.
Oh, there you go. Sorry. So I mean, it took me about 2 hours to get through all the adhesions thoracoscopically and find the ends. I found we found his upper pouch. I also found a traumatic fistula, which I ligated with 5mm stapler. I dissected out his lower pouch, which there was still a persistent fistula. We divided, and then I was actually able to mobilize the 2 ends together and get them together. I think it was quite lucky. And he's done quite well. He does have a stricture, which is we're dilating about once a month, and he's now learning to eat. So he was in the hospital the first almost 6 months of his life. And my basic comment here is this child had a gap at one point of 2.5 centimeters that I think certainly anybody on the panel, whether you did it thoracoscopically or open, could have fixed. By classification, the International Esophageal Atresia Group, a gap of 4 centimeters, you have to have a gap of at least 4 centimeters to be considered a long gap. So we should be able to get all those together. And here's a case, and the indications for the magnet is you have to have a gap of less than 4 centimeters. And you're getting an incredibly high stricture rate in multiple strictures. And so I just wonder a bit, and this is his esophagram after his repair. So I have some concerns. I'm not completely against magnets, but I would argue that a patient who's got less than a 4 centimeter gap should be amenable to a primary anastomosis. And we would, of course, do it thoracoscopically, as I think most of the people on the panel would, with maybe a 20% stricture rate. And certainly this child, because of this, the Flourish device, this patient was taken care of in an institution where they should never have been treated. Which is, if that device had not been available, this patient would have been transferred to a center that could have treated it, and and had all the modalities. So I'm concerned more around the ethics of the device and how it's being applied than necessarily using the device. And it'll be great someday if we don't need to operate on kids and we can do all their anastomosis minimally invasively. But I think this, Bethany, is something that maybe should have been done at your institution or at Dan's, but certainly not in the middle of nowhere, that in a place that doesn't have a full-time surgeon. That's what really concerns me about this, is that this device, people are going to think because you don't have to operate that we can do this. So anyway, that's my presentation.
So if I could just comment, I would definitely agree with you on basically all of those points. And I was not involved in this case directly, but after getting some feedback, my understanding is that there was some using of it that was against the advice of some of the cook reps, et cetera. So I do think that we do need to be responsible of using devices where you use it responsibly and in places where you'd be able to operate if there were a problem. I also do agree with your point that not everyone with, a 2 centimeter gap should get a magnet. I think it's, something that can be used in select patients, particularly patients who have cardiac disease or who've had previous operations that might make them less of a candidate for a reoperative surgery, or an increased risk of the anesthetic for whatever reason. Additionally, sometimes these have been used as a staged procedure. So rather than do, internal traction stitches, if that's the practice, there is also a possibility of trying to get the 2 ends together closer surgically and then using a magnet just for the anastomosis portion as a possibility.
That's great. Thanks, Bethany. Thanks, Steve. We're 15 minutes, I think, past the end of the event, and we could spend the next 4 hours talking about this. I think it brings up a whole lot of issues, not the least of which is the preoperative workup to make sure that there isn't another fistula, and whether that patient got bronch, things that there are lots of strong feelings about how to manage patients even before they undergo any kind of treatment. I'll just tell you, our experience with the magnets has been in the type of case that you just described, where a patient who had a complex airway reconstruction, median sternotomy, where we attempted to salvage a previously operated upon esophagus, and I was able to get a stitch to pull the 2 ends together, but could not do an anastomosis because it was too tight. And so then, rather post-operatively, after recovering from the airway reconstruction, rather than going back in, we used magnets. But we knew that the 2 ends of the esophagus were right next to each other, and that prevented potentially a very difficult operation. I think, Mac, you have some experience with the magnet as well.
Just one, and it worked sort of, but there was a dense stricture that required lots of work. Never got another operation, but did have to get dilated and G-tube feeds for a long time. So again, I think it's a good concept, and we're searching for the right patient.
I have a patient that's like what you just described, and this was actually it's a 23-week preemie who was 340 grams when born, and it was a pure atresia. And every time I look at this kid, the kid gets sick, and we've actually gotten the ends together, but I'm sure it's going to be a problem. And I'm thinking the magnets may be a good way to, because every time I go in thoracoscopically, but the kid decompensates for 2 weeks after I do it. And so and we don't really know what the basic lung. And so I think that is probably an excellent case for this. My biggest reason to present this was not to say that magnets, I mean, I do think that, if you have a 2 or 3 centimeter gap, if you can't sew that together, then send it someplace you can, because I think that's the best outcome for the child. But I do think that I'm concerned that I don't even know how a device like this could end up in the hands of the people who it ended up in. And I think centers like you that are doing complex things and studying things, it's appropriate, but I am terrified that this is, and plus people need to know that this is one of the complications. If you put in magnets, you may get a fistula. And I've heard of other cases like this, and I tried to identify them, but I was not able to get specifics. But I think besides stricture formation, there are other complications. And I just think this needs to be done in the right institution. It's not a license for people who say, well, I'm not comfortable doing the operation, but if I can put in magnets, I can do that, and we can just keep the baby here. I think that's doing those kids a disservice.
Yeah, it's a great comment. It gets back a little bit to Vic Garcia's earlier comment earlier this morning, talking about the FDA process for getting devices into use.